My name is Katharina Greindl. I'm a midwife and I was working for MSF the last 3 years. I did 4 missions. Before I went on my first mission, like each expert, I did the PPD, this preparation course, to know what's more or less going on in the field. But as a midwife, I prepared myself personally because you have to prepare yourself. And I did it by, as I knew I'm going to face new situations, I was asking the doctors in the hospital where I was working before if they explain me better how they handle pathologies. In a typical job profile, as far as this is existing, you do normally ANC, which means antenatal care. Then you do PNC, which is postnatal care, and maternity, so which means deliveries and problems around pregnancy. And family planning. When I was working in Nepal, it was a bigger hospital, and we were actually focusing on maternity. So we had 120 deliveries a month, and yeah, that's what I did. And I had to manage the hospital, so you have to manage the national staff, you have to manage the duties, the supply, so there are many works besides midwifery work as well. There you have maybe a little bit an idea what's going to happen, but when you come there, it's totally different. You just, suddenly you have 100 women waiting for antenatal care. You never did manual work like this on patients in Austria, and suddenly you have to do everything with your hands. You have to start to look at the patient to see what is the problem. You have to start to smell to understand what is the disease. So you really, what is the problem? You really have to learn again just by seeing and by feeling and by touching what is the problem. You have much more responsibility than in the hospital in Austria. Because in Austria normally you have a gynecologist or you have a doctor which is specialized in obstetrics, which normally you don't have in the field when you go into a project. For example, when do you have to do a C-section, a cesarean section, or when do you have a vacuum extraction, when do you have to give oxytocin. These decisions normally you have to take on your own, or you can discuss it maybe with another medical doctor, but you have to find a consensus. Actually, you are learning by doing it, but you get with MSF very good guidelines, which is one especially for obstetrics and midwives, which is called Obstetrics in Remote Areas. And you can always take it and you can read it and you get all the information you have to know and you have to get. And normally there are also very experienced national staff which can help you to learn, but it depends on the country. Yeah, so in Nepal, for example, it happens quite often that the women in labor come into the hospital and they got some oxytocin already in the village by the traditional birth attendants, by the TBAs. And they get overdosed because they give a big amount of oxytocin. So they come to the hospital with dead babies or babies in a very bad condition but still in labor. So you have to take the decision what to do, because sometimes they don't have contractions anymore. Can you still wait and start again after some while? Do you have to do a C-section immediately? Do you have to do a vacuum extraction? So these in Nepal it was extremely difficult to take these decisions. Yeah, what I miss normally most is to have a colleague which does the same work as I do, to do conversation, what can we do next, what would you do, just to have a little bit of safety or backup. This is what I think I miss most. Another thing is that you don't have ultrasound. If you learn midwifery here, you're used to have an ultrasound if you're not very sure about the position of the baby, if there's a hemorrhage, if you have, how old is the baby. You just, the only possibility to see how big pregnancy is, you do some fundal height with your hands, but you never have the possibility to be sure. Of course you get quite creative sometimes because you don't have the things you have at home. So you normally look how the national staff is working and you learn a lot from the national staff sometimes. And if not, you invent sometimes. As we don't have, for example, incubators, and we have preterm babies, which means small babies. We explain the mothers that they have to keep them very close to their breast and to their body, that the baby stays warm. Yeah, the challenge, of course, when you work as a midwife in the field is to do the best for the pregnant women and for the babies, and to save their lives if they come in a very bad situation or already. But the frustration is that you can't do it sometimes because they come too late to the hospital. Sometimes they go first to traditional healers. Maybe they have a long way to come to the hospital. Maybe it's rainy season, there's no possibility to come to the hospital. So these are the frustration in our work, that very often the patients come too late to the hospital. And then the big challenge is to make the best out of this bad situation already. The responsibility for the newborn is much bigger than here in Europe or in Austria. When the baby is not doing well, actually we have to do the reanimation. If there's a doctor, you can ask him to help you, but if not, you have to do it. And this is something you really have to learn, because here we really don't do it. We have an anesthesiologist, a pediatric or a gynecologist. So that's something I also had to learn by doing it. Family planning we do with MSF. The thing is that family planning very often is not very accepted in the places where we are working. So it's very hard to convince women, or very often also their husbands, to accept family planning. Yeah, when I was working in Haiti the family planning works quite well, and the patients were coming to the mobile clinics and asking for family planning. The thing is that not many take the pills. They prefer getting the injection because it's easier. They just get it every 3 months, and they just have to come every 3 months, and it's for free. And the injection is also something you can hide. You have the possibility to learn to work differently like you do it here. And here in Austria and Europe, obstetric gets very medically. You forget sometimes that the woman in labor is a human being. It's just like so many machines you have on the left, on the right, and you learn again to see the patient, the woman. You can't prepare yourself in a proper way because you're going to face anyway something you didn't expect, I guess. But the only thing I can say or can tell somebody who goes the first time to the field is just try to relax, because you're going to learn it with time. The first month it's really difficult, and after 2 months you think, okay, now maybe. And after 3 months you feel like, okay, now I feel a little bit more confident. So it's very important to give yourself time and don't stress out yourself. That's really difficult. And always ask. Ask when you have questions. You have a medical coordinator you can call. You have always a backup and the possibility to ask. And that's also something you should never forget.